lumbar spine here, the bottom is here, the head is, so cranial is towards my left up here, caudal is towards my right. We already put the reference array into the iliac crest on the contralateral side. So this is the left side, this is the right side. What I make sure, especially if you do an operation where you're going to use navigation throughout the procedure and you're starting off with pedicle screws, you want to make sure that you really stabilize the patient. And I use a lot of tape to really tape down the skin. I pull the skin down sometimes towards the bottom of the table to really get everything tight, nice and tight, so nothing is moving, especially in patients who are a little bit more obese. Once I've done that, I mark the midline with a marking pen. I mark the iliac crest, and I put in my reference array on the other side, which is something that we did already, and we got a spin, of course, already as well.
And Roger, one thing is, for non-instrumented cases, you just basically tape the reference array onto the skin, right?
Yes, yeah, I showed that earlier. So for a case where we don't put in screws, where you can tolerate maybe 1 or 2 millimeters of inaccuracy, then I just tape the reference array to the skin, exactly like I showed that earlier. Yeah, but obviously for pedicle screws, we want to make sure everything is really is very, very stable, which it is here. And then I start with putting in the pedicle screws. So, for example, if you're doing MIS TLIF, I always start with the pedicle screws because where's the camera, by the way? Oh, there. I should probably look there, right? So for the pedicle screws, then the pedicle screws obviously require the greatest accuracy. So I start with that first. I make 2 incisions for the MIS TLIF. We're only going to go through the screw placement here, and maybe I'll show you how I place the tubular retractor, or the trajectory at least, a little bit later. So for the skin incision, I'll make 1 skin incision on the left side, another one on the right side, and I plan the skin incision in the perfect trajectory for the pedicle screws. So that's the L4. Can you see that on the screen there? The navigated, you see that, the trajectory? So that's the left-sided L4 pedicle, and this would be the perfect trajectory, obviously, into the pedicle, right in that little valley there. That's really where you want to dock. So I mark that on the skin. I go to L3. Let's say we do L3, L4 in this case. I mark the same trajectory for L3 on the skin. And then I either make 2 skin incisions, or I make one skin incision. I connect the 2 skin incisions. If this is the side where I'm going to drop the tube for the facetectomy, I would mark the skin incision a little bit more medial, because I'm going to make a second fascial skin incision a little bit more medial to drop the tube. If this is the side where we just put in the screws, I'll just connect the dots and make the skin incision. So we're going to do that now here. So then I continue down either with blunt dissection or sharp dissection down to the fascia. So the fascial plane, then you can see here the muscle, the fascia. You can see that actually the navigation is really nice and accurate. I'm right on the muscle fascia.
Hey, quick question, Roger.
Yeah.
We're captivated by your timepiece there. Can
What
you
is
tell
the
us a
time
little
right
bit
now?
about that?
I'm sorry, what?
We're captivated by your timepiece. Can you tell us a little bit about it?
Oh, should I cover it or should I show it?
No, it looks great. I think it looks good.
Thank you. I can't tell, I'm not supposed to talk about company. I made it myself. How's that? So the first thing here is I want to make sure that navigation is accurate, right? With open surgery, you have the luxury of seeing all types of anatomical landmarks to confirm accuracy. With MIS, you don't have that. So the first thing I do is I do finger dissection through the muscle in the Wiltshire plane down to the T-piece. And now I feel the T-piece of L3 here, and I put the pointer on the very tip of the T-piece, and I look at the screen, and you see how you have the tip there. The tip is blue, or? Tip's blue, yeah. Yeah, so the tip of the instrument is blue, and you can see here how I'm really straight on the T-piece, right? I go up and down on the sagittal views, and it looks perfectly accurate. So this is very, very accurate. So that's, in my opinion, that's the best way to really confirm accuracy. So I'm at L3 here, and now I'm pointing towards the trajectory for the entry point for the pedicle screw, And I will ask then the assistant here to simulate a screw, just so I know in terms of length and size. So maybe like a, yeah, 6'5", 45 or 50 or something like that. And some surgeons like to drop the screw so it's there. I just do this for sizing now. So this seems like a reasonable size pedicle screw. So I'll take this out. And now I want to start with the preparation for the pedicle screw. Now, this particular company has something that's really nice, which is a navigated drill or burr, right? Which is actually really nice. A lot of companies don't have that, and I've always been envious, and I wanted to use it. I've never really used it, so I want to use it here to mark the entry point for the pedicle screw, because as you can imagine, this patient has pretty corrugated bone, and you want to mark the entry point so you can find that easily with your tap or whatever instrument, whatever other instrument you use to get into the pedicle. Now here, the pedicle screw system that we have here is not a single-step pedicle screw system. This company has a different system that's single-step, other companies too. So in this case, we kind of have to prepare the entry hole and then tap before we put in the screws. So I'll use the drill. So or the burr. So this would be the perfect entry point here for that pedicle. So I lift it up a little bit, and then I drill the entry point for the. So that would be the. So can we mark this here so I can find this? You can even go deeper, I guess, huh? So, yeah, 20 millimeters. Wow. Okay, so we can do that. I like it already. Okay, now we'll come out, so we mark that. So now we have, see, and that's the thing with freehand navigation. That's something with a robot you can't really do. Namely, that tactile feedback that really makes you 150% sure, makes you feel safe and sure that the anatomy is right, you're in the right spot. And that's kind of what I like about freehand navigation versus the robotic navigation. So now I have the awl here, the tap. And I'll go back into the anatomy, and I'll find that hole that I prepared with the burr. And now you can see I'm dropping into that hole already. I realign the trajectory of the awl here with the trajectory that I created with the burr. And now we're in cancellous bone, so you don't have to push a lot. And that's the other thing with navigation. Don't push, don't lean on the spine. I don't like malleting things. Everything should go really with minimal effort and with minimal pressure and pushing. So now we're basically going into the pedicle. It works out very nicely here. And we'll go past the pedicle a little bit. So now at this point, I would ask them to put the trajectory, or we can use the same trajectory, I guess.
Hey, Roger, at this point, do you ever get an AP X-ray to check your accuracy at the beginning, or do you normally don't do that?
What X-ray, Christoph? There's no X-ray. We don't need X. The whole point is nobody wears lead here, and there's no X-ray. The X-ray is banned, and the X-ray techs are banned. That's the whole point.
So there's no secondary verification except for your magical.
No, you don't need it because you feel everything. I put my finger in. Where else am I supposed to be? I know exactly where I am. Now I know what time it is too because I've done it for a while. So now we have that pedicle screw simulated here, and again I put in the screw. And I follow that trajectory with the screw. And then every once in a while, you kind of let go a little bit to see where the screw really is, because as you're moving things up and down, right and left. So every once in a while, you can let go to kind of get a better sense where the implant really is. But this all looks pretty good. And then obviously you get the tactile feedback. So this feels really good. All right, so this is now... So this is the pedicle screw here. And then should we do the same thing on the other side, at the other level? So we can do, that was L3, and I always start with the screw that's further away from the reference array because that's theoretically less accurate, right? So you want to do that in the beginning. So I drill the hole for the L4 screw. I really like this navigated drill.
You won't tell your brain lab friends.
So, but again, you're right with I mean, obviously, if you have a concern, yes, you should get the X-ray and you should get a confirmation or a spin. Don't get me wrong. I mean, safety is the most important thing here, and this is the tap. But I tell you that navigated drill is really something.
Yeah, I really like that drill for percutaneous decortication of the contralateral facet joint. Works really well.
Yeah, exactly. You can do that also. Yeah, get into the facet joint. Yeah, so that feels all good. So, and then the hands-off test, let go. So now the screws are in on one side. Obviously, the assistant would put in the screws on the other side. So if this is the side now where I'm doing the T-lift, I would make a medial fascial incision for the tubular retractor. If you take the screw off here, just take the yellow screw off, or the extension, the yellow extension off.
Hey, Roger, can I ask you a question? Do you ever make a midline incision and pull the skin over above the fascia?
No,
You
because
always make a lateral incision.
lateral, because if you measure this is about 5-6 centimeters. If you wanted to go this far lateral on both sides, you would have to make a huge incision.
So do you ever split the difference between where you want your T-lift incision in the fascia and the pedicle screws? I kind of look for pedicle screws, then T-lift, and then I make split the difference with the incision and then figure out where to go from there.
Yeah, on this side here, on the left side, I would make the skin incision a little bit more medial, because for that reason, that's true. So, but now this would be now the entry point. This would be the entry point for the tube. So I'm aiming towards the inferior edge of the L3 lamina there, and this would be the position or the location of the fascial incision that I would make for the tubular retractor. So that would be about 1 centimeter more medial maybe. So that's the second fascial incision.
Do you always do a second fascial incision, Roger? Or?
Well, for the T-lift part, yeah, I make a more medial incision, and now I go with the pointer, and now this is where I would dock. This is where I would put the dilators here. See, that's the lamina. That's the lamina, and then that's the step off here. This is all overgrown here, but this is where I would put the dilators in now, and I would dilate and put the tubular retractor, and you see. Because I dock more medial than probably most of you, it doesn't really interfere with the pedicle screws. It never really interferes with the pedicle screws. That's why I can leave I can put in the pedicle screws, and I'll just work around that. And then I bring in the microscope and do my facetectomy. That's really it. And then once the tube is in, then I start drilling. I start drilling here, the inferior edge of this is kind of I start drilling at the inferior edge of the lamina, which is a little bit hard to see here. I start drilling here, and then I drill towards the pars, which would be, it's right here, the L3 pars. On the sagittal view, you see that. So that's my second landmark for the T-lift. I drill from the inferior edge of the lamina to the pars, and then you can disconnect the inferior articulating process, and then I use navigation to basically find all these different landmarks. And then when you close up, obviously, you got to make sure the multifidus muscle is here in the middle. So you don't want to push that muscle down when you put the rod in. So you got to go underneath the muscle. That was it, really.
Well, there was a really nice presentation from Roger here.
Thank you. All right, thank you, Tate. Thanks, everyone. All right, any questions? That's it?